Hello, everyone. Good afternoon or good morning. My name is Kyla Retzer. I am the coordinator for the Center for Motor Vehicle Safety at the National Institute for Occupational Safety and Health. The center is hosting today's webinar, which is titled Marijuana and Driving: How to Keep Your Fleet Safe. I will be serving as your moderator. The NIOSH Center for Motor Vehicle Safety views the topic of marijuana use as an important consideration for all employers, including carriers who employ commercial drivers and employers whose fleets are composed primarily of light-duty vehicles like passenger vehicles. A few opening comments on the topic of marijuana. The number of US states that have legalized marijuana in some form covers more than half of the country and is increasing. According to the National Survey on Drug Use and Health, in 2018, over 40 million American adults reported using cannabis at some point that year, and nearly 5% of the US population 16 years or older reported driving under the influence of cannabis. Like alcohol impairment, impairment from cannabis is associated with an increased risk of being in a motor vehicle crash. However, testing for cannabis impairment is complex as compared to testing for alcohol impairment. Today, we are honored to have two excellent speakers who will provide us with important information about the effects of marijuana use in general and on driving, explain the legal and testing considerations for marijuana impairment, and provide suggestions for how employers can manage workplace driving risks associated with marijuana use. Following their talks, we will have about 30 minutes for speakers to answer your questions. We have muted all participants to avoid interruptions, so we ask you to please submit any questions you have via the Q&A box at any point during the webinar. Questions will be addressed during the Q&A portion. If we don't get to your question during the session, answers to select questions may be posted on the webinar events NIOSH webpage and published in the next NIOSH Behind the Wheel at Work newsletter following the event. Participants in today's webinar will also receive a link to the recording once it has been closed captioned and posted on the CDC's YouTube page and the webinar events NIOSH webpage. I just want to make mention that we have muted the speakers. And I think we've covered those portions. So we'll begin with Dr. John Howard, who is the director of the National Institute for Occupational Safety and Health and the administrator of the World Trade Center Health Program in the US Department of Health and Human Services. Dr. Howard was first appointed NIOSH Director in 2002 during the George W. Bush administration and served in that position until 2008. In September of 2009, Dr. Howard was again appointed NIOSH Director and was reappointed for a third 6-year term in 2015. Dr. Howard earned a Doctor of Medicine from Loyola University of Chicago, a Master's of Public Health from the Harvard University School of Public Health, a Doctor of Law from UCLA, and a Master of Law in Administrative Law and Economic Regulation, and an MBA in Healthcare Management, both degrees from George Washington University in Washington, D.C. Dr. Howard is board certified in internal medicine and occupational medicine. He is admitted to the practice of medicine and law in the state of California and in the District of Columbia, and he is a member of the U.S. Supreme Court Bar. He has written numerous articles on occupational health, policy, and law, including on the topic of marijuana. And I will turn it over to Dr. Howard.
Oh, thanks, Kyla. It's my pleasure to be with you today, and especially to be with Dr. Hartenbaum, who is a noted expert in this area. So my job is to give you a bit of an update, sort of an overall update about the uses of cannabis sativa. And Kyla, just want to check and make sure you can see my slides okay?
Yes, I can.
Okay, great. So there are three major uses: industrial, medical, and non-medical, which is a nice way to say recreational, which you often see. You know, we've seen the fact that cannabis has been around for thousands of years as a plant. And has been used. Even George Washington planted cannabis on his plantation and used it to make canvas and rope and all sorts of things. Recently, 2018, cannabis itself with a percent of THC, the psychoactive ingredient in cannabis sativa, of 0.3 or less, was removed from Schedule 1 of the Controlled Substances Act, making it an ordinary agricultural product called industrial hemp. Now, some people get confused a bit about marijuana versus hemp, but hemp is cannabis sativa with fairly high levels of CBD or cannabidiol and low levels of THC. This is industrial hemp, where marijuana has higher levels of the psychoactive THC, lower levels of the CBD. So the medical use has also been around, you know, for thousands of years. I make a point that marijuana was actually listed in the United States Pharmacopoeia, which is the legitimate medicine sort of list, from 1850 all the way up until 1942. The non-medical use is quite complex in terms of the products that are available now. It really is almost mind-boggling. And the percentage of THC that are in those various products. And they vary from basic marijuana plant products, or phytocannabinoids, as they say chemically, from 0.5 to 5%. Hashish a little stronger, hashish oil a little stronger. And now we've seen a lot of these concentrated THC products that have THC levels from 60 to 80%. And some dispensaries even say they have products in 90 to 95%. So this is a wide range of THC. Now, you know, as Kyla mentioned, we wish we knew more about workforce use. As she mentioned, we have some data from 2018 from SAMHSA that gives us some idea of the percentage of workers who are employed for full-time, who are users. It's hard to figure out what percentage of them use it monthly, daily, etc. But year over year use from 17 to 18, the proportion of full-time workers reporting lifetime, past year and past month cannabis consumption is about 1.4, 7.3, and 7.2. So it is becoming more popular. We don't have industry and occupation data. That's really what we lack, and we certainly don't have a lot of data on the specificity of occupational drivers. Now, as we mentioned, there's three kinds of cannabinoids, or these chemicals that are found in cannabis sativa: the phytocannabinoids, which we see from plant materials, and then endogenous cannabinoids. We'd be very surprised to learn that there are actually cannabinoids that are produced by our own brain. And then we have these sort of fake marijuana things called synthetic cannabinoids. So there's a lot of chemistry associated with what are called the endocannabinoids. These are actual receptors primarily in our brain. Cannabinoid receptor 1 is in our brain, discovered in 1990, and cannabinoid receptor 2 in the brain, but mostly in the immune system. And there are these chemicals that the brain produces, anandamide being one of them. That's a neurotransmitter in our own brain. And so, you know, one of the issues is, well, what is the function of this system? Recently discovered, and it differs from most neurotransmitters, as we'll see. Usually they're stored in the presynaptic neuron. They're released in the space between the pre and the post, and they affect the postsynaptic. Endocannabinoids actually do the opposite. And they're made only when needed. They don't seem to exist as some other neurotransmitters like endorphins exist. And they act as what we call retrograde messengers. So they actually go from the post to the presynaptic. And these two, anandamide and AEA, these are the two chemicals. And this is just a little cartoon showing you that they're released from the postsynaptic neuron and they influence the presynaptic. They sort of work to tone down things. They move in that direction. Very different kind of chemistry. But they're distributed widely in the brain in very important areas: the amygdala, the hippocampus, the midbrain, the nucleus accumbens, a same area that a lot of drugs affect, like opioids, for instance. The functions of this retrograde signaling is probably to tone the brain down, like a brake in a car, slow things down. Psychologists are trying to figure out, well, what is the function of these chemicals in the brain? And some of the research has indicated maybe they help us forget things. You know, you park your car in a parking garage. Well, you maybe do that every day and it's a different spot every day. Well, you don't want your brain to remember every day where you parked the car. You only want it to remember the last day. So maybe it's a type of proactive interference. The other thing that's been discovered, chiefly in the VA, is the role of cannabinoids, and especially marijuana, in PTSD. And that is something that's being discovered. Now, synthetic marijuana, fake marijuana, is one of the new psychoactive substances. This is not from a plant at all. It's not from our brain, but it's made by some chemist. And I use that word loosely. It has a lab in the back of their garage. A lot of names for these things, Spice and K2, there's a whole bunch of other names. And they're basically sprayed on plant material. It doesn't even have to be a marijuana plant. They use anything. And then you smoke it, you vape it. You can buy these synthetic marijuanas everywhere. And what's interesting is at the present time, they're not detected by most standard urine testing. And so a lot of workers that are subjected to a lot of urine testing in the workplace tend to be using synthetic marijuana. The federal government has tried to keep up with this. In 2012, they listed 26 new synthetic cannabinoids, but boy, it's hard to keep up. These clandestine chemists are very busy, and they sort of elude DEA's capability. The health effects, I think we're all aware of acutely: dizziness, dry mouth, nausea, vomiting, drowsiness, somnolence, euphoria, disorientation, sometimes even hallucination. You know, Colorado has an interesting experience in their emergency departments where they take care of people with acute cannabis intoxication. Their emergency department visits increased 40% between 2012. So the chronic effects, I think, we're also aware of, and cannabis can be associated with dependency and withdrawal, can create anxiety, irritability, insomnia. And what happens when a consumer of cannabis experiences these kinds of withdrawals symptoms, fails to maintain work, school, or home responsibilities, essentially has a tolerance, using more and more cannabis to get the same effect, and exhibits about 9 or 10 other exhibit. The American Psychiatric Association, in their Diagnostic and Statistical Manual of Mental Health Disorders, DSM-5, calls that cannabis use disorder. And I point out in 2018, 2.1% of adolescents, which is about 500,000 people, 5.9% of young adults, 2 million, and 0.9% of adults aged 26 or over, again from SAMHSA data, suffered from cannabis use disorder. The National Academies of Science have been investigating the health effects, what kind of positive things can result. There seems to be conclusive or substantial evidence for treating chronic pain in adults, especially neuropathic pain, from, let's say, low back injury. And as we know, that is a common injury in workers and probably very common in truck and passenger vehicle drivers that do it for a living. So I mentioned that to you. Also, as an antiemetic, very substantial evidence for treating chemotherapy-induced nausea and vomiting, and also helps treat spasticity in multiple sclerosis. The rest of the indications are probably not substantially or conclusive. And certainly the United States government is not convinced of the medical benefits of marijuana. 2011, the governors of Rhode Island and Washington petitioned the DEA to move it from Schedule I, which makes it essentially illegal to prescribe. It took a few years, but my department, the Department of Health and Human Services, issued a 5-part test saying this is how we're going to do the judgment. And after a while, in 2016, they issued their Federal Register notice, which is quite lengthy, saying marijuana does not meet any of the 5 elements necessary for a drug to have currently accepted medical use. However, it has not inhibited some drugs from gaining approval by the FDA, synthetic THC, to actually treat nausea and vomiting associated with cancer chemotherapy. Or very recently, a pharmaceutical grade cannabidiol, a CBD oil that is used to treat 2 rare childhood epilepsy syndromes. You know, we talk about the THC and the psychoactive nature of the issue, and we're worried about whether consumption among workers leads to increased workplace safety issues. And this is hard to sort out, and we do have literature on it. Certainly, the most recent study indicates that there may be some association there. But what's really fascinating is this more recent study, which looked at states with marijuana reforms and showed that there was actually almost a 20% reduction in the suspected number of workplace fatalities. And the authors seem to indicate that it may be because people are substituting, workers are substituting marijuana cannabis for opioids for pain. Certainly, when we look at this in more detail, there are more papers, one recently published in 2020, that show that these marijuana reform laws that states have reduced the use of prescription opioids. So there seems to be some sort of transference going on here among workers, and that may actually end up being a useful tool in combating a prescription opioid epidemic. So let me just briefly end with some of the discussion about the legal issues. As Kyla mentioned, this is quite an interesting history leading up to the state reform laws. But basically, marijuana was quite legal, quite used up until the 30s, and 1937 is when the Marijuana Tax Act came in. It basically abolished the legitimate medical use. And in 1970, in the Nixon administration, marijuana, cannabis sativa was placed on Schedule I by the Controlled Substances Act. And Schedule I has other neighbors like cocaine and heroin. These drugs cannot be prescribed by a physician. A physician could recommend them, but they cannot be prescribed, or the physician would lose their DEA license. And here's an example of the kind of drugs that are in the various schedules, and you can see heroin, LSD, marijuana, peyote is in the Schedule I. These drugs have no medical indication according to the US government. Now, as Kyla mentioned, we've got, right now, at least 33 states and DC have passed laws broadly legalizing marijuana. We have 11 states and DC that essentially have the most expansive laws. And then other states have laws for CBD and other things that have limited use of medical marijuana. Certainly the trend here is in an increasing number of states. It's not just looking at marijuana and making it recreationally or medically legal. They're also decriminalizing the possession and use of small amounts, sort of making it an administrative, like a ticket, instead of jail. They're also expunging the records of people who have been convicted of marijuana possession crimes. And certainly, you know, the last thing I'll point out is this uncertainty that employers have, and rightly so, about the legalization of cannabis consumption on the state level while federal prohibition still exists. And certainly Dr. Hartenbaum is going to discuss more about that. It is a difficult period of time for employers to be looking at this issue. We live in what's called a dual sovereignty republic, and that means that there's a federal government and there are 50 state governments. Employers often can run afoul of legal issues. One of the biggest is, do employers have a duty to accommodate an employee's use of marijuana? Well, no state requires an employer to accommodate cannabis consumption in the workplace. 12 states and DC, though, have adopted express employment provisions that prohibit an employer from taking action against an employee in hiring and termination and imposing other penalties if that employee has qualified under their state reform law for medical cannabis use. Clearly, there are exceptions if the worker is found to pose a safety risk. But as some of you may know, Nevada became the first state to legally prohibit, with certain exceptions, an employer from denying employment to a prospective employee just because the prospective employee submitted to a drug test that the employer required and the test was positive. That went into effect this past January. Also in May, the New York City city government has passed similar laws. One of the defenses that employers often use is say when they do terminate or refuse to hire someone who may they may take that action because of marijuana use. The defense usually is, well, gee, you know, federal law prohibits medical marijuana. And certainly that defense holds for federal contractors without any doubt. But in a state employer situation, most courts that have ruled it early on, from 2008 to 2016, have agreed with the employer argument. But I do point out that not every court has agreed with the employer argument, saying federal preemption is my defense. A U.S. district court in Connecticut, in a famous case in 2018, and also an appeals court in the state of New Jersey also. So we may see more courts moving in this direction against the employers saying federal preemption is the reason I do it. I think the lesson that we can learn is that zero tolerance drug policies could actually increase an employer's liability, and that drug testing policies that an employer may have should account for the state anti-discrimination, because an employee may sue under state law saying you discriminated against me. So I think employers should also be aware of the growing list of cannabinoids that may violate federal law. And this duty to accommodate, I think if you want to avoid a court battle, given that a number of states are writing these employment protections into their cannabis access laws, I think it's important for you to rethink that. And I think employers in those kinds of states need to confirm whether a positive drug test are connected to state certified medical use before they jump to a employment decision to terminate. And I think reasonable accommodation policies may need to be revised because, you know, if you have somebody who has a state certificate to take marijuana, you may not want them in the most safety sensitive jobs, and that may be entirely appropriate for an employer to take that action. Lots of workers' compensation issues, you know, can a workers' compensation claim be denied if an employee tests positive for using a state-sanctioned marijuana? Or can an injured employee seek reimbursement for medical marijuana to treat a workplace injury? The courts are kind of a little separated here in terms of the employer not requiring. The Maine Supreme Court has ruled there. New Mexico, a little different. The court held that marijuana may be a reasonable and necessary medical treatment. So it's a little workers' comp law in progress. Florida and North Dakota have expressly prohibited reimbursement, whereas New Mexico established an actual maximum reimbursement amount in its worker compensation fee schedule. So those are two diametrically opposed. And as you know, we have 50 different state worker compensation systems, so you have to check with your own state's worker compensation system. Clearly, there's a lot of research studies undergoing review now, looking at marijuana and its relationship in workers' compensation setting. So the last word, of course, has not been written here in this area. So I provided a number of references for you, and happy to answer questions when it's question time. Thank you.
Thank you so much, Dr. Howard. And I'm going to introduce the next speaker. Excuse me one minute. Now I'm pleased to introduce Dr. Natalie Hartenbaum, who is President and Chief Medical Officer of OccuMedix, an occupational medicine consulting firm located in Dresher, Pennsylvania. She is certified by the American Board of Internal Medicine and the American Board of Preventive Medicine and Occupational Medicine, and has a Master's of Public Health in Occupational Medicine. She has been a certified medical review officer since 1996 and has been listed on the FMCSA's National Registry of Certified Medical Examiners since its inception. Dr. Hartenbaum has extensive experience in the clinical, corporate, and academic settings and is a nationally recognized expert in occupational fitness for duty with a special focus on transportation. Dr. Hartenbaum is the editor of the DOT Medical Examination, an unofficial guide to commercial driver medical certification, now in its 7th edition, and CDME Review, a quarterly newsletter for commercial driver medical examiners. She has published and lectured nationally on various issues of fitness evaluations in the workplace and is the course director for the ACOEM's National Registry of Certified Medical Examiners. Dr. Hartenbaum holds a BA in biology from Temple University, an MD from Temple University School of Medicine, and an MPH in occupational medicine from Medical College of Wisconsin. And I will turn it over to you, Dr. Hartenbaum.
Okay, thank you. And let me just go ahead and get my slides up and share. And of course, I somehow am not on my first slide. So give me 1 second to get back there. And now we're better. So hopefully you can all see my slides now. Thank you very much, Kyla. And thank you, Dr. Howard. I'm just real excited to be here this afternoon or this morning, depending on where you're located. And what I'm going to really try to do is go over a bit of what we know. And unfortunately, I'm going to be telling you a lot about what we don't know on the impact of cannabis when it comes to fleet safety. So nowadays, it's very hard to do any presentation and not at least talk about the elephant in the room, COVID-19. And indeed, COVID has had some impact on DOT drug testing. So review what the current issues, current status might be. A little bit about the current cannabis regulations, drug testing regulations and such that will affect drivers. And then what we know and a bit of what we don't know about the effect of cannabis on driving abilities and the association with crash. A bit about cannabis drug testing. It's a very complicated issue. I did see one question came in during Dr. Howard's presentation on hair testing and how that may impact cannabis, and I'll mention that. And then the more important piece is how do we evaluate impairment in individuals who are using cannabis in the workplace? And then wrapping it up a little bit on policy and testing considerations, and really what do employers need to do to keep themselves safe, to keep themselves covered, and to try to do the right thing to the extent possible. Now, starting with COVID-19 and FMCSA, I'm going to focus primarily on this FMCSA rather than the other DOT agencies' drug testing issues. Recognizing that there might be difficulty in finding testing locations, recognizing that many breath alcohol technicians were not comfortable doing breath alcohol tests during the pandemic, recognizing that some drivers may not be willing to go into a medical facility. Early on, ODAPSI, followed by its agencies, including FMCSA, put out notices that they would be waiving some enforcement actions if certain conditions were made. And over the past several months, FMCSA has revised some of those waivers of enforcement action. And at the current time, the random variances goes to the end of the year. That's been extended from the end of June to the end of September, and now it goes to the end of 2020, which basically if an employer is unable to meet their random testing requirement, and if they are unable to reasonably spread that random testing throughout the year, there's going to be a discretion to not have enforcement action against them. But the employer must, the carrier must document that they've made a reasonable attempt to meet the total requirement and to spread it to the extent possible. One of the other big changes is that currently under the normal regulations, if a driver has been in a program but not actively working, perhaps been on furlough, been on leave for 30 days, had still been subject to testing, they wouldn't require a new pre-employment drug test. What's recently happened is that that's been extended to 90 days to address all the drivers that are on furlough and now trying to come back. If they've been in a program, they may not need new pre-employment drug testing. The employer, the carrier, still does need to check that clearinghouse, does still need to check older past employers for any violations and then make certain that appropriate steps had been taken. Currently, that expires 9/30. Whether or not that will be extended throughout the end of the year, we may find out shortly. As far as post-accident and reasonable suspicion testing, if it is impossible, and I truly mean impossible to get that testing done, again, DOT will look at that carefully and decide whether or not the employer made a reasonable attempt, as long as it is documented. So the really important piece of this is if you can't meet these requirements as a carrier, you must document that. I know DAPSI kind of explained to employers that, or reminded employers, it is the employer responsibility to determine whether or not the driver who didn't stay, didn't show up, couldn't provide a specimen outside of that shy bladder evaluation situation, which is the MRO, they need to determine whether or not there really was a refusal or there's a reasonable explanation. I was ill. I was terrified because I'm incredibly high risk, but have to document that decision. And then finally, the Office of Drug and Alcohol Policy and Compliance through the Department of Transportation has also put out a more recent requirement or a recent variance that those service agents who are required to have specific training or other qualification criteria met and are unable to meet it because of the pandemic could have that requirement waived through now the end of September. So if you haven't met it, you have to go catch up quickly. And the other very important variance that was provided or waiver of enforcement was for the substance abuse professional. Currently, that staff evaluation needs to be done in person, but given the circumstances, if this can be done remotely, as long as there is sufficient technology, as long as the staff is able to adequately assess all those visual cues and the individual's activities to make that interview remote, that can be done, but again, documenting how that's being handled. Now, on those relevant regulations, there was probably the most important one from the Commercial Motor Vehicle Operators, 391-41B12, and that clearly states that the individual does not use any drug or substance identified in 21 CFR 1308.11 Schedule 1. And if some of you may remember, probably about 10 years ago, the regulation didn't specifically call out a Schedule 1 substance. It was any controlled substance, amphetamine, narcotic, or other habit-forming drug, and then the regulation was changed as medical marijuana began to be used across the country. So specifically, any Schedule 1 medication is now prohibited in a commercial motor vehicle operator. We'll talk about CBD a little bit later on, but currently CBD may or may not be a Schedule 1 substance, depending on how it is derived. If it's derived from the hemp plant, something that is defined as hemp under the new hemp bill, with a 0.3% by weight of THC, no more than that, no product being more than that, and it could fall under a non-Schedule I substance. If, on the other hand, the CBD is derived from the marijuana plant, if there is more than 0.3% by weight of THC in that plant or any product derived from that, it would still be a Schedule I substance. Very complicated issues with CBD. One of the other concerns that we have is that if for any reason marijuana is taken off of the Controlled Substance Act, is no longer listed as a Schedule I substance, under the current executive order that began federal drug testing, there would no longer be permitted to test marijuana under the federal drug testing programs. We'll talk a bit more about that again in a few more slides. FMCSA has made it abundantly clear, no questions asked, if a driver is using medical marijuana, whether it's in the U.S., whether it's because the country where they live it's legal, recognizes it is recreational adult use, is currently legal in Canada, and if they're operating in the U.S., they still are not permitted to use marijuana, end of story, not even a discussion point. Employers need to remember that there are other regulations, 392.2 and 392.4, which again talk about a driver using transporting, or not transporting, but using a controlled substance, a Schedule I controlled substance, or being under the influence or impaired by any medication. When I talk about impairment, I'm going to primarily be focusing on cannabis, but we need to keep in mind it's a lot of the same concerns if an individual is using an opioid or even using an over-the-counter impairing medication. Now, the drug testing regulations, very simply 49 CFR Part 40, the procedures for transportation, workplace drug and alcohol testing programs. I've heard a number of people still referring to this back as OTETA. OTETA is the Omnibus Transportation Act, which really began the regulatory process for drug and alcohol testing in the U.S. By that act, we can only test for substances that are in Schedule I or Schedule II. Currently, the only approved specimen that can be collected is urine. We know it has its limitations, especially when it comes to marijuana. In urine for marijuana, as well as for cocaine, we don't test for the parent compound. We test for a metabolite. The issue is whether that metabolite is psychoactive or not, whether that produces a high, whether that can cause cognitive impairment. Oral fluid, one of the nice things about oral fluid is that the window of detection is a little bit shorter, gives you a better idea of more recent use. And it's soon. The Department of Transportation published in the Federal Register last week the announcement about the new custody and control form. The major changes on that new custody and control form is having a place to indicate if oral fluid was collected and whether or not that second specimen with the oral fluid was also collected. Now, hair, I put a question mark under. We don't know quite when hair is going to be approved, if ever, but also last week, the SAMHSA, Substance Abuse Mental Health Services Administration of the Health and Human Services Department, or Department of Health and Human Services, published a proposed mandatory guideline on hair testing for federal testing. And asked a number of questions. It may be proposed to only be permitted for pre-employment or random, and I think the reason for that will be clear the more that we go through this session. What you all need to keep in mind as far as DOT testing for hair is, first, we have to have that mandatory guidance finalized by DHHS, by SAMHSA. Then the agency, Department of Transportation, would put out their proposed rule with a comment and notice period. Then they would put out their final rule. So we're probably at least a year or two away from hair testing being approved as part of the federal drug testing program. And then the other more specific, agency-specific regulations are 49 CFR Part 382. The panel does include marijuana, and it is specifically the marijuana metabolites that we are testing for. This slide came from a recent Motor Carrier Safety Advisory Committee meeting where ODAPSI presented kind of the concerns that they had on the changes in marijuana status across the country. They reminded everyone that we currently have a five-panel drug test, which is really 5 categories that we test: THC, cocaine, amphetamines, opioids, and phencyclidine. And on the right side of this slide, you see the THC or marijuana, cocaine, and we actually confirm for benzoylecgonine. The amphetamine, we have several different amphetamines that we test for, and several opioids, as well as PCP. The red are the Schedule I, the black are Schedule II, and if there's any change, then there might be a problem. What FMCSA has, DOT has indicated is that they are working with various groups to make certain that we hopefully will be able to continue to test for marijuana should the status of it on the Controlled Substance Act be changed. Now, I didn't want to give you a lot of chemistry, but I thought it really was important to at least share a couple of slides to lay some background. On the left-hand side, if we go down just that second chemical structure, and I'm not sure if my arrow is pointing it out or not, is CBGA. It is a precursor of both the end product of THC, the delta-9 tetrahydrocannabinol, as well as cannabidiol, which is CBD. So they both come from the same parent compound, but they do not metabolize back and forth to each other. On the right-hand side of this slide, I wanted to remind everyone that THC is the main psychoactive ingredient. That's 11-9-carboxy-THC, or as we call it, delta-9 THC. And that metabolizes to an 11-hydroxy-THC, which is also psychoactive, also can produce a cognitive impact, can also produce a high, but that then metabolizes to carboxy-THC. Carboxy-THC is what we're testing for in the drug test, the THCA. And that is not psychoactive, and that does last for quite a longer time. So that is really part of the problem that we're dealing with when we're trying to find out whether a person's impaired because of the urine drug test. And the answer quite simply is you can't conclude impairment based purely on a urine drug test result. Over the years, the Department of Transportation has put out several marijuana notices reminding employers, drivers, medical review officers that medical marijuana is not a legitimate medical explanation for a positive drug test for THC. In 2012, with recreational marijuana spreading across the country, they again reminded everyone that the medical review officer will not verify a drug test is negative based on the recreational adult use because it's legal in their state. And earlier this year, because of all the problems considering CBD, because yes, CBD can potentially cause a positive federal drug test for THC, and we'll talk about why that is in a bit later. But they reminded everyone that CBD is not a legitimate medical explanation for a laboratory-confirmed THC positive. They do not test for CBD. CBD is not regulated by the FDA as far as concentration, as far as purity, and therefore it is essentially a use-at-your-own risk, buyer's beware situation for CBD for the federal drug testing individuals. And I included the website for many of those announcements. And one other federal regulation I want to just bring in here is the OSHA General Duty Clause. One of the biggest concerns about the use of cannabis in the workplace is the individual going to be impaired? And is the individual going to injure themselves, or are they going to injure their coworkers? And under that General Duty Clause, each employer is required to furnish the employee a place of employment that is free from recognized hazard likely to cause death or serious harm to the employees. With some recent, or not quite so recent anymore, changes in the recording and reporting of occupational illness and injury criteria, there was concern about whether or not a post-accident drug test could be done at all. And OSHA clarified that yes, post-accident drug testing can be done under certain circumstances, certainly if it's required under the Department of Transportation rules. Drug testing can also be done to evaluate the cause of a workplace incident that harmed or may have harmed individual employees. What's very important to remember, and why I want to stress why it's important to remember, is because when you get information, you have to know what you're going to do with it. So if you're doing post-accident testing under OSHA, you may or may not be able to do it under your state law, because some states significantly limit when you can do post-accident testing, perhaps by what type of job it is, perhaps by the degree of hazard that was there. You must test not only the individual who's injured, but anyone whose conduct may have contributed to that incident. So you may find a lot of results that you have to figure out what are you going to do with it, which is one of the reasons the most important thing for everyone to be doing right now, for every employer to be doing, is to really take a very close look at your policy. We'll talk about policies as we go on. A lot of later on, but we're going to be talking about a lot of things as we go on, trying to now lay some background. Now, just July, a couple months ago, the National Institute of Drug Abuse put out a really nice marijuana research report, which if you're really interested, it just has a lot of good information on it. But it talked about the cognitive effects of marijuana on the brain. And we need to separate out cognitive effects, impairment, crash, accident, and other bad outcomes. And they're not necessarily all absolutely leading from A to B to C. It depends on lots of different factors. When we look at marijuana's effect on the brain, Dr. Howard talked about the different receptors, but we know that there are receptors in the area that's responsible for higher cognitive function. We know that there are receptors. We know that cannabis can impact memory. It can impact learning. It can impact motor control and other coordination. But there's a lot of factors that may impact exactly how that effect may be manifest. Marijuana is not the same as Marinol. When we're looking at Marinol, which is a THC product, FDA approved, we know how much of the active ingredient is there. We know what the duration of action is. We know what the dosing interval is. When we're looking at cannabis, whether it is smoked, vaped, injected by edibles, it may be different. It may have different amounts of the delta-9 THC. It may have different amounts of CBD. It may have products such as delta-8 THC, which is also psychoactive and would not be picked up in a drug test. It may have 5% THC. It may have up to 90% THC. So the active ingredient amount may significantly vary how that's going to affect an individual. Whether they smoke it, whether it's vaped, whether it's ingested, it can also have some very significant effects. And the next slide is going to point some of those differences out. And then the person's body habit. Marijuana deposits in fat cells. That may impact the effect, how long the effect, and whether or not you may still find some of the metabolites several days, weeks, or even a month down the road. Now, just looking at two main routes of consumption and how the effect of cannabis may differ. Smoking and vaping is absorbed to the lungs. There's no pass elimination. It goes from the lungs to the brain. We see maximal plasma concentration within minutes. And within just seconds to minutes, we see that effect, that high manifesting itself. The maximum effect, 15 to 30 minutes, the person smokes or vapes, wait a little bit, and they're going to feel that effect. And slowly over the next 2 to 3 hours, that effect will start to dissipate. Unlike smoking or vaping, when there's oral ingestion of cannabis, it goes through what's called first pass elimination through the liver. And it's converted to another active ingredient of an hydroxy-THC, which is absorbed much slower and for a much longer period of time. And why that is important is that those psychoactive effects don't begin for 30 to 90 minutes. And when cannabis first became legal in Colorado, they were seeing a lot of ER visits with individuals who had their one cannabis brownie, didn't feel anything, had their second cannabis brownie, maybe were starting to feel something and then had a little bit more. And then an hour and a half later, they're now really feeling the effects of that cannabis. The effects can last 2 to 3 hours. I mean, the effects maximum is 2 to 3 hours. So at the time the smoking and vaping is just starting to wear off, that maximum effect from the oral ingestion is just beginning. And it can last 4 to 12 hours. So the question of how long is the person impaired, potentially high, potentially under the influence of cannabis, really depends on that concentration, but also on how it is consumed, how it gets into the body. Now the challenge really is there driving impairment? And the bottom line is we don't know. We know there's impairment. We do know there's driving impairment, but is there an increase in crash? And that's really where the studies have changed. If we look at a lot of the older studies, there seems to be a consistent, yes, increased crash risk, yes, increased accidents, yes, increased impairment. Some of the more recent studies are a little bit more maybe, but we're not sure the degree to which. And one of the biggest factors has been found to be the use of alcohol concomitant with the cannabis. And cannabis, individuals who are driving may act one way. If they have alcohol on board, they act differently. If they have both on board, different still. So in a recent study, kind of found out the results, and this was a meta-analysis, so it looked at a number of studies. The marijuana use was associated with significant cognitive psychomotor effects. And yes, acute impairment was found, especially in those who were using it intermittently, infrequent use. But those who were using it regularly, they weren't finding the same degree of impairment. In Canada, where it's now currently legal, they did, again, a number of studies looking at a meta-analysis, and they found that there was impairment, and they recommended restricting safety-sensitive duties for at least 24 hours after using cannabis, or longer if there was concern about ongoing impairment. A number of studies looked at what happened after Colorado and Washington State legalized marijuana, and they did find that, yes, fatal crash rates did increase, compared to control states, those where it was not legal but not significantly so. And this seemed to be changing after the commercial dispensaries opened. And then again, another prospective study, Canada found that the levels maybe were the difference. That in their study, drivers who had a motor vehicle crash and had a cannabis level less than 5 nanograms per ml were less likely to be involved in a crash. But if the cannabis level was above 5, there was a higher risk of having that crash. So maybe that 5 was the right level, but other studies say that 5 isn't the right level, and are we actually testing properly, and other issues. And then another very recent study, which I found quite interesting, was chronic heavy recreational use was associated with worse driving performance, even when the individual is no longer under the influence of cannabis. So even when they're no longer intoxicated, they still have impairment. And they found that this was primarily associated with those individuals who were using cannabis at an earlier age, less than 16. And the thought was perhaps this correlates with the early increased impulsivity. So there are a lot of factors that can really go into whether or not there's increased crash risk, or really just that impairment, which may or may not be causing the crash. Going back to that National Institute of Drug Abuse study from earlier this year, marijuana significantly impairs judgment, motor coordination, and reaction time. And it does appear to be a direct relationship between blood THC concentration, blood, not breath necessarily, definitely not urine, and impaired driving ability. It was the most frequent illicit drug found in the blood of drivers involved in vehicle crashes, including the fatal ones. And those drivers who had THC in their blood were roughly twice as likely to be responsible for that crash than those who had not used drugs or alcohol. But the bottom line that they concluded was that the role of cannabis on actual crashes was a bit unclear, because it could be found in the body fluids for quite a number of days, probably well beyond when the individual was under the influence or impaired by it. And as I mentioned earlier, often combined with alcohol. And those vehicle crashes where there was THC in their blood, they were more likely than not to be responsible for the crash than those individuals that had not used blood, drugs, or alcohol. Was this impulsivity? Was this the cannabis? Was it the population? A little bit harder to tell. And the risk with marijuana in combination with alcohol seems to be greater than either drug by itself. Now, we're very aware that alcohol does increase crash risk. Whether or not cannabis by itself does, we'll talk about that. Dr. Howard had mentioned the National Academy of Science, Engineering, and Medicine study the health effects of cannabis. And I'm just going to quote a couple of other statistics or information conclusions from that report. And looking at injuries, they did find that there is an increased risk of motor vehicle crashes, that there is an association between cannabis use. But there's no or insufficient use to support a relationship between occupational accidents or injuries. And as mentioned, there may even be a decrease depending on the studies that you're looking at. From a psychosocial perspective, yes, there is impairment in cognitive domains of learning, memory, and attention. And there may be, but it is limited. Even with abstinence from cannabis use, there may be longer-term impacts on cognitive domains of learning, memory, and attention. The Governor's Highway Safety Association looked at a number of studies after marijuana was legalized in Washington and Colorado. And they found certainly that marijuana use significantly increased in both states, and that the presence of THC in arrested and crash-involved drivers increased in Washington state, but interestingly, not in Colorado. Fatal crashes involving marijuana increased in both, but again, you cannot automatically assume that because it was present that it was responsible. Many marijuana users did drive high because they felt that marijuana did not affect their driving, and they often will drive high, and there's no firm conclusions whether crash rates were changed or not. And another analysis from Rosenberg in 2016, again, that acute intoxication is associated with a statistically significant increase in motor vehicle crash risk, and driving under the influence appears to be concentrated in that higher risk category. Now, what seems to be really interesting is that individuals who are under the influence of alcohol tend to be more impulsive, they tend to take more risks, they tend to drive more quickly. While those that are under the influence of cannabis and recognize that they may be impaired actually drive more carefully and drive more slowly, which may or may not decrease the risk of motor vehicle crash. And then just one more study from NHTSA, the Marijuana Impaired Driving Study report to Congress in 2017, has been shown to affect a number of driving-related skills. Laboratory simulator and instrumented vehicle studies have shown that marijuana can impair critical abilities necessary for safe driving. One of the problems, again, which we are well aware of, is that these were based on simulator studies. They were not real life, naturalistic, is the individual under the influence while they're driving in a vehicle. They found that the drivers tend to drive slower and take less risks. So are they safer? Maybe. Is the slow, meticulous driver unsafe? Possibly so. The other very important finding in this study was looking at the time course of THC concentration in plasma, looking at performance decrements, and then the individual's subjective high. If you look at the pink line, the concentration in the plasma goes up very quickly, and then it gradually decreases over the next 2 to 3 hours. If you look at the green line, that's the performance, the percent of baseline. So a person's doing okay, they smoke their marijuana, it goes down, and then their impairment gets even worse and worse and worse before it starts going back up. And if you look at that dark blue line, you can actually see that the subjective high starts to go down where the individual still has a significant amount of impairment. So there truly is not a correlation between subjective high performance and THC levels. Going to driving, again, looking at the Governor's Highway Safety Association, and these are not every state because I couldn't fit every state on the slide. And this is current as of 1/30/2020, and things have been changing rapidly. But a number of states decriminalize, have medical marijuana, have recreational marijuana rules on the books. Some of them have zero tolerance laws, which basically means if there's any THC, any metabolite found in the system, you're assumed to be under the influence and it is a violation. Others have what's called per se laws, where they will have a reasonable inference. It's presumed that you are impaired if it is above a certain level. So every state is a little bit different, but the problem is it's not very easy to always get blood levels at the scene. So we really do need a better tool, and we don't quite have that yet. We've heard a lot about cannabis just like alcohol. The problem is we don't know, or we do know how alcohol works. We know if an individual has 1, 2, 3, or 4 drinks. There was a very steady linear increase in the level over time, and that blood alcohol concentration gradually goes down over a number of hours that is consistent with the amount of alcohol consumed. Marijuana, and you've already seen it's very much the same slide, is not consistent. The level of THC goes down very quickly while the individual may still be significantly impaired. One of the concerns that we need to have is that cannabis is certainly the most frequently found substance. And looking at the data from the FMCSA clearinghouse from May of this year, marijuana was by far the most commonly reported substance in this FMCSA clearinghouse. These are test results that have already gone through medical review officer review. So it is not simply the lab found it, but yes, the lab found it, and it was not due to Marinol or some other legal, not state legal, but federal legal substance. And what's also interesting is that a recent Quest drug testing index found that marijuana use has increased significantly between 2018 and 2019 by 11% across all industries, with a 53.3% increase in transportation and warehousing. So we do know that our individuals who are working in transportation industry, who are working in the warehousing industry, are using cannabis at a much significantly higher number than they had back even a couple of years ago. Now, what are our tools for measuring use of marijuana? And that's what it does. It measures use of marijuana. It doesn't really necessarily measure impairment, and that is our challenge. The urine, which we're all very familiar with. In the infrequent user, you may see cannabis in the system, THC or carboxy THC, for about 1 to 3 days. The habitual user may see it for up to 30 days. Oral fluids, that shorter window of detection, 24 to 36 hours. But one of the problems with oral fluid, which may come up with some of the tests that will be used, is that passive exposure can cause mouth THC. There could be a small amount of it, perhaps up to even 3 hours, if they're smoking, if someone nearby is smoking, and they may not be. The use of hair, repetitive use up to 1 to 3 months. and you're really looking at one of the metabolites, but you can find a high concentration of the parent compound, but even that could be environmental contaminant. So it's really, again, has to be interpreted and washed clearly a certain way, and we need certain types of protocols to make sure that any testing done is consistent from lab to lab. Now, blood really is very short window of detection, 3 to 4 hours. It does measure the active ingredients as well as some of the metabolites, and this does appear to be the best hope for finding that relationship with impairment. The American College of Medical Toxicology has a recent statement that came out on the interpretation of urine for tetrahydrocannabinol metabolites. And it reminds everyone, you can't just look at the result and say they're impaired. We know that these tests are not designed to identify the synthetic cannabinoids, does not identify CBD, and it does not identify impairment at all. So just looking at urine tests does not tell you definitely whether or not is impaired. The level can be affected. I talked about the duration. It can also depend on how much THC, the percentage of THC that was ingested. And yes, just the immunoassay, the screening test can lead to false positive tests, but it's why it's very important that any confirmation, anytime you get a positive immunoassay screening THC, that you go ahead and do that GCMS confirmation testing, because that really would give you a more definitive test. And then the THC, carboxy THC, can last for a much longer period of time. While there have been a number of reports in the literature that gastric acid can cause CBD to turn into THC in vitro, that is true. It does not appear to happen in vivo. It means it does not happen in a normal person. This was a study where they used synthetic gastric acid, and the CBD did eventually turn into THC, but it does not seem to happen in the normal person, normal situation. Now, the question that keeps coming back is, will I test positive if my CBD contains less than 0.3%? My CBD contains less than 0.3% of THC, it probably is legal under the hemp law. The problem is this is not overseen by the FDA or any other administration. There have been numerous studies, there have been numerous reports, there have been numerous letters sent by FDA and from other organizations that have found that CBD is frequently mislabeled. It can have significantly more THC than you may see on the label. But what's even more problematic that people do not seem to understand, that if they take 1 4-gram gummy that contains THC and then take another one and another one, they're adding the amount of THC they have in their system. Whether or not that's going to become psychoactive or not is debatable, but certainly it will show up in a urine drug test. When you're looking at CBD oil, that contains a half a teaspoon, contains 5.46 milligrams of THC. And yes, if you use enough CBD oil, that also can end up popping a positive urine drug test. And under federal testing, as I mentioned much earlier, the MRO has absolutely no choice but to call that a positive drug test. So the recommendation is know where you get your CBD, know how much THC is in there, and make sure that you're not using too much of that THC-containing CBD if you're going to be subject to federal drug testing. To make this just a little bit more complicated, we have the Hemp Act, which does allow a certain amount of THC in CBD. We also have a number of states that have cannabis laws which allow for high CBD but low THC in their products. And not all of these currently have a mechanism to distribute the CBD, but these are on the books and I want you all to be aware of them. Georgia will allow a CBD product that contains up to 5% of THC. South Carolina and North Carolina, 0.9% of THC, as does Tennessee. And then Virginia will allow no more than 5% of THC as well. So if the individual is purchasing their CBD in the dispensaries consistent with state law, the use of that CBD may be in violation of federal law. They make it a little bit more complicated, probably. The Department of Transportation, again, this is the Motor Carrier Safety Advisory Committee, and ODAPSI again pointed out that, yes, they are aware that CBD may result in a positive test. And they really are urging everyone, and this is why I wanted to include these slides, to warn drivers, to make drivers understand that while they may be legal to buy, labeling is not always accurate. A significant number of these were mislabeled and a significant number had a much higher level of THC than was reported on the label by the producer. We need to also remember that CBD cannot be sold to have health benefits, promoted to have health benefits. It cannot be added to food, and if it is in violation of the Food and Drug Administration, and therefore technically is not legal, even if it does contain less than 0.3% by weight of THC. So knowledge is key. Driver needs to be aware if you test positive, if you use CBD, it is not a valid excuse. The medical review officer has absolutely no option, but must report this as a positive test, must now report it to the Drug and Alcohol Clearinghouse, and it will remain on that driver's records for up to 5 years. That driver will need to go through any required substance abuse professional evaluation, any required return to duty testing, and then ongoing testing during the follow-up program. And whether the driver pays for that or not, they just need to keep in mind that use of CBD, while not prohibited, could really have some very significant implications. Currently, there are a number of federal agencies. The Department of Defense has already noted, the Navy, Pentagon, CBD is absolutely not prohibited, and the Pentagon quietly tried to make CBD a criminal offense. Now, at the same time, there's been a lot of action in Congress, a lot of action in the House of Representatives. There's one's being voted on, I think, next week, which may have some significant impact on the legalization of marijuana at the federal level if it were to also pass the Senate. And that's really the issue. It has to pass both the House and the Senate. But there was recently a bill also passed in the House of Representatives, not yet in the Senate, that would allow military troops to use CBD, in contrast to what the current status for military troops would be. I know some of you probably have heard about the Cbd Thc ratio, which is done by LabCorp or Metox, and they do promote that this is one way of distinguishing whether or not the THC found in a urine specimen is due to CBD use or from marijuana use or from both. Now, if you look at it, they do give the caution that interpretive ranges are provided as guidance and should not be considered definitive. And that is absolutely true. First of all, there's a very wide range that is indeterminate. So if you're lucky enough to have a concentration of CBD to THC that's less than 0.1, you know for certain that it is THC. If it's greater than 10, it probably is CBD, but it is possible to study for that test, just like many others. So it is possible that the individual may have used their THC on Friday, may find out that they're going to be getting drug tested, and then go ahead and smoke or vape a large quantity of high percentage CBD, which could upset that ratio when they go for their drug test. So while not necessarily likely, it is possible. Regardless of the CBD THC ratios, it is not permitted to be used in federal drug testing. Now, when it comes to evaluating impairment, and I know this is all the answers that you want to everything is the answers. And unfortunately, there really aren't great answers to this because we don't know whether the presence measures impairment or not. We don't know how predictive they are. We don't know how much impairment is too much impairment. Let's first of all talk about the different tests to identify whether there's THC, the active ingredient, in the person's system. And there's a number of saliva tests that are available. There are a number more that are being developed right now. And one of the concerns is whether or not there may be an effect by passive exposure in some of these tests. They've been used in multiple locations, and the results come within 5 minutes. Again, some concern about those. There's a lot of work being done right now on breath testing for marijuana, and Houndlands is one, Cannabis is another. And those will more likely be useful, but again, do they necessarily equate with impairment? Probably more so, because they certainly will correlate with more recent use. And then another breathalyzer developed by the University of Pittsburgh. Now, what I think is important is to think about, are we looking at just drug testing levels? Are we looking at whether it's in the saliva, whether it's in the breath, or are there ways to evaluate true impairment? A lot of the work on evaluating impairment actually came out of looking at fatigue and looking at the cognitive effects of fatigue and the impairment resulting. The problem is that fatigue, is that impairment necessarily going to cause a motor vehicle crash? And that's really where the questions come up. There's a number of different products available. One is called Blue Sky, also known as Druid. The app is called Druid. And then there's something else that's called the Alerter Meter. And then there's many other ones as well, which measure predictive. They have the individual either memorize something, either follow dots, either identify what's different. They also promise, but are they absolutely going to be accepted in litigation, in forensic types of environments. There's other types of measures for impairment, which is vehicle-based. And again, that's more fatigue looking at, where it looks at whether the individual has lane departure. It looks at whether the individual's eyes are closing. It looks at whether they're going out of their lanes or not, whether their speed is changing or not. So those are all various tests, but none of them are absolutely perfect at this point in time. I think our best hope is that we will eventually have a breath test for cannabis, and because you can identify current or very recent use, hopefully that will help us to say, yes, the person is more likely than not impaired. However, that does not necessarily give us any kind of deterrence. And if we think back to why was the central drug testing program put in place, it was not necessarily put in place except for post-accident to be identify who's impaired, but more of a deterrence type of program. Now, we really would like to see more standard is some of the sobriety testing. And the American Transportation Research Institute put out a really nice document looking at legalization and some of the solutions. Now, only 21 states have all law enforcement officers trained in the standard for the standard field sobriety testing. And there was a second category called the drug recognition expert. And only 17 states have more than 20% of their law enforcement trained in that type of program. And that's the Advanced Roadside Impaired Driving Enforcement Program, the ARIDE program. It's about 40 to 60 hours to be fully trained. They're trained not just the secrets or how to do the field sobriety testing in more detail, but other signs that they may use to recognize whether the individual may be impaired or not. The standard field sobriety test uses horizontal gaze nystagmus, a walk and turn, and then one leg stand. And then there's other things looking at horizontal nystagmus, looking at pupil size, that these officers who are more advanced training can recognize impairment. Remembering that when we look at roadside impairment, it's usually just step one, and the individual then goes on to that forensic measurement, that breath alcohol testing, or going to the hospital and getting a blood test to see if they truly appear to be under the influence and not just impaired by something. And it's one of the important things for employers to remember when they're thinking about impairment. The impairment may be due to cannabis, it may be due to oxycodone, it may be due to Benadryl or diphenhydramine. It may be due to not getting enough sleep. It may be due to a medical condition. So we need to think about impairment as a broader category, and how do we identify impairment? How do we train our supervisors? How do we train our employees to really be careful about being impaired regardless of the underlying cause? Now, a little bit on state law. Can using marijuana consistent with state law get you fired? And the answer there even is maybe. Dr. Howard mentioned the different state laws and how they can be very challenging. One of the things to keep in mind here is that if you are a federal drug testing, if it's under a federal drug testing, take that aside. Federal drug testing using marijuana, using THC, being in your urine, yes, that is not permitted. The thing that you need to remember is that one policy does not fit all companies. One policy does not fit all states. If you have a multi-state company, you need to be aware of what the requirements are, what's permitted in each of those states. Some states, when it comes to cannabis, has employee protection. Some states require this employer to accommodate. Some states even have protections if there's recreational or adult use, not just medical. So you need to make certain that you have partnered with an attorney who is closely following these, not just what the regulation says, but also the cases, because the case law is really going to make the difference in what you can and can't do going forward. Whether or not you can do a post-accident drug test depends on whether or not the state permits it. Whether or not you can have a policy that differs depends on whether the individual may be in a safety-sensitive position. Some states define safety-sensitive positions. Other states allow the employer to define what's safety-sensitive. Some states allow the employer to take action if the individual has a positive test, if it's safety sensitive, others do not. So very important to remember that define your jobs, define safety sensitive, be aware of your state requirements, and be aware of the changes. For those states where there are employee protections, all of them essentially do prohibit use while at work. They prohibit being impaired while at work. They differ on what you can do with a positive test, and as I mentioned, it depends on whether or not the individual is in a safety-sensitive position. It differs on whether or not the state has protection. They also differ on whether or not the individual can use marijuana cannabis off-duty. Some will permit the employer to take action for use of cannabis off-duty, defined only a drug test. Others will not. And they differ significantly, as I keep on mentioning, on safety sensitive, and they differ on whether or not you need to use a level of cannabis found on that test, and they differ on whether and how you can measure impairment. So marijuana limitations also depends on who you can test, when you can test, how you can test, and then to make things a little more challenging, under state law, many states have different cutoffs. So just saying you're going to mirror federal drug testing may not always be appropriate because different states use different cutoffs. In many states, the cutoffs for different substances are higher than under federal testing regulations. Do you need an MRO? Not every state requires medical review officer review. I would, however, urge you to have someone who is trained in interpreting drug tests to do all of your reviews and not just look at what the lab says, because sometimes the lab results really need a lot of interpretation. Sometimes the medical review officer needs training, and interestingly, Hawaii actually requires the medical review officer who is reviewing tests in that state to have a Hawaii MRO license. You don't have to be licensed in Hawaii, you just need to have a Hawaii MRO license. Now, a number of organizations have called for a common sense approach to legalizing marijuana. Not saying that marijuana should or should not be legalized, but keeping in mind that there may be safety implications. And bottom line is we don't know enough. We don't have the ability to identify impairment. We don't have the objective test to say whether the individual is currently under the influence, but we do know that marijuana does cause some types of impairment. And the ATA not only recommended additional studies and looking at oral fluid testing and impairment standards, but also a marijuana victims compensation fund paid for by dispensaries for those individuals who are injured by those drivers who are using cannabis and then end up causing a adverse complication. The American College of Occupational and Environmental Medicine back in September of 2018, marijuana is impairing substance and its legalization has used public health implications. There may or may not be health benefits. There may or may not be significantly increased risk, but it's important that before Congress passed any legislation, the impact on workplace safety needs to be remembered, not just workplace injuries, not just illness, but really, is this going to be a problem in safety-sensitive positions? And the National Safety Council, they believe that it's unsafe to be under the influence of cannabis while working in any safety-sensitive position. There's also several who feel that it's unsafe to be under the influence of an impairing opioid if you're working in a safety-sensitive position. For the National Safety Council, they recognize that research is clear that cannabis impacts psychomotor skills and cognitive function, but at this point, we do not have the ability to identify the amount of THC detectable that correlates to a specific unacceptable level of impairment. Now, what are the next steps? Just a couple of final slides before I wrap up and we open this to questions. I said policy, you've got to review your policy. You've got to look at your policy and update it as needed. You cannot have a single policy anymore. That went out probably about 10 years ago. You may be able to have a zero tolerance policy depending on where you're located. You may be able to have a zero tolerance policy depending on whether your jobs are safety sensitive or not. But usually you can't have a zero tolerance policy. If you are doing drug testing, make sure you're testing when you're permitted to. Some states you cannot test, or one state you can't test for marijuana pre-employment, Nevada. New York City, you can't do pre-employment testing for marijuana in New York City. There are some states you can't do pre-employment testing at all, except in safety-sensitive positions. In some states, you can't do random drug testing, except in safety-sensitive positions. So it's very important, again, to recognize and to identify what is a safety-sensitive position. And then document how you assess workplace impairment. Impairment is not only going to be due to cannabis. It's not only going to be due to oxycodone. It's not only going to be due to diphenhydramine. And to only send an individual and assess impairment by simply sending them for a 5-panel drug test really is going to miss a number of individuals who may be impaired, may be significantly impaired, that is not going to show up on that drug test alone. Work with a knowledgeable legal team. Whether it's internal or external, you need to make sure that your legal team is closely following the marijuana laws, closely following case law. You need to educate your employees on the danger and impact of both alcohol and drug use. And I urge you to also educate them on the impact of CBD on any type of drug testing they may be involved with. Training managers and supervisors on the policy, on their responsibility in the policy, and what they do if they should identify an employee who appears to be impaired, and then recognize and document that sign of impairment. There already is some required testing for supervisors in FMCSA drug and alcohol testing programs that reasonable suspicion impairment training, but you probably want to periodically update that and make sure that some of them can even recognize the different types of impairment, the different types of physical findings they may see with the different types of drugs. And then follow the situation closely and then go ahead and repeat it again and again. And that is the end of what I have to say this afternoon. So going to stop sharing my slides.
Thank you so much, Dr. Hartenbaum. That really highlighted how complex marijuana use is, and that we do have about 9 minutes for questions. The presenters, if we could get our videos on, that would be great. Thank you so much. So I'm going to start with 1 or 2 questions that were received in advance of the webinar. And the first one has to do with regulations on the federal level. So what happens if or when marijuana is taken off of the Schedule I list? And I'll open it up to both of the speakers.
Oh, I'm going to let Dr. Hartenbaum take the first crack at that.
I think it really depends on what happens. It depends on how the legislation goes. If marijuana is totally taken off of the Controlled Substance Act, it becomes a non-scheduled substance, then there would need to be some kind of safety carve-out in order for us to be able to continue testing for it as part of a federal drug testing program. That also has implications as many states limit the drugs that can be tested to those substances that are approved under federal drug tests. The hope is that either it will be a safety carve-out or perhaps rather than taking it totally off the Controlled Substance Act, it may be moved into a Schedule II. So we really just don't know, but we need to watch closely. We need to make sure that our congressmen recognize the issues of safety at any legalization that steps that are taken.
Okay, thank you. A question from today in the Q&A box is, can ADAS, which is Advanced Driver Assistance Systems, be used in judging impairment and render reasonable cause testing? And the second part of that question, will fatigued drivers be discriminated or targeted in reasonable suspicion for marijuana?
Dr. Howard, do you want to address that one?
No,
or?
no, you take that one.
Nope. I take that one too. I think yes, the first question is, will a driver who's driving erratically, who is not going, staying in lane for the driver who is starting and stopping and kind of hesitating, will that be addressed? Will that be identified? Probably yes, again, depending on how the system is set up. The challenge, and I get mentioned very briefly, is that impairment is impairment, whether the person's impaired because of cannabis, a legal opioid, an over-the-counter medication, hypoglycemia, or sleep apnea, fatigue caused by sleep apnea, it's the same thing. So people should understand they can't operate a motor vehicle impaired, and that really is the bottom line.
Thank you. And this next question really gets back to some of the statistics that Dr. Howard, you presented early on in your slide deck. And it's, do you think people in legal states are more likely to report use in those states than where it is illegal? This may skew the data.
Yeah, I think it's entirely possible. It clearly something that's illegal where you live, although it's a smaller number of states, as we know. That would be a disincentive to participate in a survey, honestly.
Yeah. Thank you. Okay. Another question. Is there any specific recommendations on how to address non-CDL drivers in states with legalized marijuana? And I know you really touched on a lot of this, Dr. Hartenbaum, but I didn't know if you wanted to reiterate any of those specific points.
I think the important thing is to look at the impairment. That we don't know. We do know that cannabis impairs. We do know that the individuals, whether they're driving a car, whether they're driving a company vehicle, whether they're driving a light truck, any impairing medication is a problem. Any impairing substance is a problem. So it really is educating them that they can't use something that may be impairing them. And like fatigue, like hypoglycemia, an individual is generally not very good at assessing their degree of impairment.
Good, thank you. Another question is regarding states with per se limits of 5 nanograms, if I'm saying that correctly. Is this a de facto judgment of impairment?
Go ahead.
This is very much like the alcohol laws. I mean, we know that 0.2 and 0.02, 0.04, the numbers we think about in commercial motor vehicle operators. In normal drivers, we look at the 0.08. Not everyone's impaired at that same level, but that is the per se level. At that level, you're presumed to be impaired. And that's really what we're looking at in the cannabis levels as well. We just don't know if that's accurate at this point in time. If many of us, if we think back, those of us have been around long enough, we remember that the legal limit for alcohol, the breath alcohol concentration, was a little bit higher a few years ago and has been decreased over the years. We may find the same thing with cannabis.
Thank you. Are there tracking of the use of ADA as justifying, I'm assuming justifying the use of cannabis? I'm hearing of 2 different cases in the East. And ADA being the American Disabilities Act, I'm assuming.
Go ahead. Yeah, go ahead.
Okay. You know, Dr. Howard mentioned a couple of cases that were ADA, and there's certain states where the employer is obligated to review the driver's medical condition using appropriate steps and accommodate. Part of it depends on what is the person's job. If the job is safety sensitive, there's a different degree of accommodations is expected. If the individual is doing a job where mild impairment will not impact his performance, his safety, and safety of his coworkers, then that accommodation degree may be very different than someone who's operating heavy machinery. So yeah, accommodations may come into it depending on the state.
Yeah, and I think this illustrates the sophistication that employers have to have these days in states that they're operating in with these employment protections, with state anti-discrimination laws, with state disability laws. It's not the same as it was years ago. You have to be very sophisticated, and you can't have these blanket zero tolerance policies. They're just not working anymore for the employer.
Thank you so much. And I guess we're down to 2 minutes, and so I just wanted to ask if you had any, if either of the speakers had any closing comments, in particular for fleet safety professionals in terms of protecting their workers from work-related motor vehicle crashes.
You know, to me, one of the most important things right now is education. It's really important that everybody understands that there's a lot that we don't know. We know there's impairment. We know it has causative effects. We know that there's an increased association with crashes, with impaired driving, and they really need to be careful and educate their drivers on the risks, and especially in those states where both medical and recreational use is legal.
Thank you.
Yeah, I would certainly agree. I think the landscape is changing so rapidly that it's important for employers, fleet managers to be dedicated to keeping up with all of the details that Dr. Hartenbaum pointed out today. And it's a massive amount of detail that you have to keep up with. So having professionals like her and others at the ready to help you, I think, is a major task for fleet managers.
Thank you both so much for your time and with all of your knowledge. And we will be following up with a posting of this webinar on the NIOSH webpage after it's been closed captioned and placed on the CDC's YouTube site. Thank you again and have a wonderful day. Bye-bye.